Welcome back, this is Paramedic Project, and thanks for joining us once again. Today, next episode in our case preparation series, we're talking about preparing on the way to a shortness of breath case. That's a really common cause for call out to ambulance, so let's get right to it. Airway causes, first of all, we can think of airway obstruction, and if it's a paediatric patient, we will say croup also. On to respiratory causes, asthma, COAD, chest infection, anaphylaxis, and then if we think about some of our anatomical layers as well, we might say pleural effusion. Onto cardiac causes, AMI, ACS needs to be high up on the list. And if we think about some of the anatomical layers of our heart, we might say pericardial effusion possibly also. On to extracardiac causes, those big pipes around the heart, PE. PE must be in your thinking on the way to these cases, simply because one of the big presenting complaints for any pulmonary embolism is tachypnea, or feeling short of breath. So PE must be on the list. On to D, other causes in our systematic assessment D, and straight away I'm thinking of anything that causes a big metabolic acidosis. And in that case, often we have a presenting or compensating respiratory alkalosis, which may present as tachypnea or patients feeling short of breath. Now those things for me are straight away, I'm thinking DKA, I'm thinking sepsis, and I'm thinking possibly tox, particularly tricyclic antidepressants. Now, a note on DKA, some people might say, hold on, diabetic patients are the only ones that get DKA. And yes, diabetic patients do get DKA and other hyperglycemic states, but actually a significant number of people who present in DKA actually present in DKA prior to being diagnosed as diabetics. And this presentation leads to them presenting at a ambulance station or at an emergency department, leading to further medical testing, which leads to a subsequent diagnosis of diabetes. So it's important to keep DKA in the mix when you're thinking tachypnea or shortness of breath. And then we might go on to E in our systematic approach and think about a head to toe assessment. We might find some source of chest trauma, fractured ribs, for example, that cause the patient to have some inspiratory pain, which changes their respiratory mechanics, prevents them from breathing deeply because they're in pain when they breathe deeply, and it causes them to breathe a bit faster. So they're the big ticket items. It's a pretty big list. It's not an exhaustive list, obviously. Now, some people might be looking at this list or might be listening and going, well, hold on, you haven't spoken about anxiety or psychogenic hyperventilation. That's because, in my thinking, the only reason I can say, or the only time I can say with any confidence that tachypnea has been caused by anxiety is if I rule out all of these other causes. So it's ruling out PE, ruling out chest infection, ruling out AMI. So really, we can't say that in a pre-hospital environment. So that's why anxiety is not on the list. Now, the line that I often find myself saying or rolling out to patients and their families is that in ambulance, we live in worst case scenario land. So that means that really we're advocating for the patient all the time, we're protecting our jobs, and it puts us in quite a risk-averse framework. And in my mind, that's the way it should be. We're advocating for patients, protecting their health, and really informing them of the types of assessment that we can do in the pre-hospital environment, and maybe then pushing them to go to hospital to get a further assessment of their shortness of breath or tachypnea. It's been Paramedic Project. Thanks for joining us once again. Hope it's been helpful, and we'll see you next time.